little bit about what you're going to do with this program. Kind of just give me an overview of how this is going to work.
This program actually really means comprehensive. Many people use the term a little loosely. When we say comprehensive, we really cover every aspect of breast care. Now, some programs are facility-based, some programs are community outreach-based. Facility-based programs, we mostly have educational programs and clinical programs. In the clinical programs, I run a high-risk clinic, which involves, genetic counseling, lifestyle modification, ascertainment of what the risk is and how we can modify and attenuate it. Then we run a benign breast clinic, so all sorts of symptoms, lumps, bumps, and all kinds of things that patients may have issues with and are struggling with, breast pain and those kind of things. We deal with that. And then we have a multidisciplinary cancer clinic. So the patient can come in and every cancer will be prospectively seen by the surgical, medical, and radiation oncologist, and if need be, plastic surgeon, to make a comprehensive plan. We target to make sure that 80% of our cancers are discussed in a multidisciplinary tumor board conference to make their treatment plan. So that's a multidisciplinary program. Then we have a survivorship program, and that also is a little different what typically is done in many places. So somebody gets cancer, they're seen again and again, but the focus of keeping an eye on them is to make sure cancer doesn't come back. To me and to this program, that's not what survivorship is about. That's just one piece of survivorship, that your lump didn't come back. But did your life come back? Are you enjoying the same hobbies that you did? Are you able to do the job that you had? You have the same role in the family, spousal relationships, and all kinds of things that are affected by breast cancer. This is a comprehensive program because we have a built-in guidelines which are scientifically based on psychological rehab, physical rehab, shoulder range of motion, lymphedema care, occupational rehab, to make sure that the quality of life of a patient gets back to where it was before the cancer happened, or as close to it, as opposed to just making sure that the cancer didn't come back. So that to me is very helpful and beneficial for people.
Your specialty is breast cancer surgery.
Correct.
Who is going to pick up when you've got metastases? Who's going to pick up? How is that going to work?
We have all the specialists in the program, and that's the advantage. Mostly metastases will be treated by chemo or hormonal therapy. So that typically does not need surgery. Every now and then metastases need surgery too, and we do that too. So if there are metastatic potential or established metastases, then typically medical oncology will see that. We might be involved in providing them access like ports and stuff to deliver chemotherapy. And if a metastatic area is deemed appropriate for resection, then we can do that. Whether it's liver, whether it's lung, or whatever that is.
Let me ask another question kind of this way, because I've been doing this kind of. We had Rusty Robinson and we had Sean Tedajara here, and they both handled other kinds of
gynecologic cancer.
Yeah, gynecologic. How have they been? Can you talk about how they've been replaced and whether they?
That is actually a void in the community right now. We do not. The Panhandle community does not have a gynecologic oncologist at this point. After we lost those two people, and I think Texas Tech. My understanding is that Texas Tech and Texas Oncology are working together to come up with some way to replace that position. That is a very, very immense need of this community. And we're trying to work towards getting somebody here.
If you're successful in recruiting that type of a position, will that position articulate with your program then?
Yes, it will. It will, and it will actually, in the big scheme of things as women's health, it will articulate. More importantly, also because some of the breast cancer treatments that we offer have gynecological side effects. Especially, for example, hormonal treatments can have side effects that are pertaining to gynecological issues. And when Dr. Tedjarati was here, we were working with him on those issues. Currently, we are taking care of those issues in our clinic but it will be a great help to us if we could recruit such a person.
Tell me a little bit about your training. I'm just kind of curious.
I am originally from Pakistan.
Okay.
So I went to medical school and did my residency from the Aga Khan University in Pakistan.
Okay.
And I'm very proud to be a product of them because Aga Khan University, as you may have heard, is a very renowned, respected, prestigious university internationally. So I finished my training there. Then I did a subspecialty fellowship from the University of Arkansas in 2002. And after that, I moved to Massachusetts. I joined the surgical oncology division in Massachusetts. That's where this need of subspecialty training was there. They did not have a fellowship training program. So we developed a training program for University of Massachusetts that now is accredited for 5 years for the subspecialty training. And I still keep in touch with them. In fact, I'm flying there next week to speak. So I keep in touch with them. So I established that program over there. I believe that they're working towards national accreditation as well. But they haven't gotten there yet. And when I moved here, I just continued with that concept and built that program.
Now, when did this program actually get the accreditation?
The actual letter we got was August 28th, 2010.
Okay.
So, but we did a pre-application last year, and then we had to collect the data and then reapply, and then the survey was August 3rd. So it was a process.
I heard you talking about data and data collection.
Right.
Because you see that as important. Talk to me a little bit about that.
Data collection is very important for multiple reasons. First of all, we are just as good as we can prove we are. So with the data, it keeps us, the physicians, on toes. We generate 6 monthly reports on the 27 quality measures that are nationally identified. You know, how often do you remove the breast? How often can you save the breast? When you remove the breast, how often do we offer reconstruction? And there are so many. There are 27 measures. In our database, we keep track of every single patient on all those 27 measures. And we generate 6 monthly reports that are discussed in the steering committee, which all the departments of multiple entities are represented there. So that provides us instant feedback. Okay, where are we lacking? Where we need to do better? Do we need to purchase another equipment? Do we need to have certain training? Whatever that data shows us. So that's one piece. The other piece, our website has not gone live yet, but within a month or so it will. Maybe earlier than that. Actually, I think maybe within a week or so we may put that live. And on the website, my plan is to put those 6 monthly reports available for the community, because that will endorse the transparency. When the community, a patient in the community can log in and say, you know, how do these people do with the stage 1 breast cancer? And they can just see our results as transparently as possible. To me, that quality will speak for itself, because transparency is a huge deal. I don't want people to believe that we are best just because we say we are best. I want them to have access to the precise information which compares us to the national database and says we are better than X number of places or not.
So what else should the people who visit my website know?
About the program?
About whatever you want to tell them.
Well, I think that, I cannot emphasize enough to this community that comprehensive is a very loaded word. And when I came here, some people did tell me, no, we have a comprehensive center. So I heard that term, and I just want the community to know that it's a huge commitment to call yourself comprehensive. It really means that you cover every aspect of care. So when I say that we have Breast Center of Excellence, it truly is a comprehensive center. It will provide every aspect of care. It will have enormous transparency of the data reporting that will be available, and we will train people for future. Now, we don't have a fellowship program yet. which we can. We have all the pieces in place. The only reason I did not start a fellowship program yet is because there's a national cap on it at this time. Because the Society of Surgical Oncology looked at some data a few years ago, and there were lots of trained people who came out and were not absorbed in the society as jobs and working people, so we stayed back a little bit. As soon as that cap is lifted, I think we'll be ready to have a subspecialty fellowship training also.
Which leads to the question then, is there a critical mass for the number of patients and a critical mass for the number of staff that would justify a fellowship program?
Yes, we have the critical number of people, we have number of clinical trials, we have the imaging and technology and the expertise to provide that training that's needed. So we have all of those. We just need the cap to be lifted so that when we train people, when they graduate out of our system, they are able to be absorbed, in various jobs or whatever they need to do in the future.
Do you have the patient load?
Yes, we do.
Okay. All right.
Yes.
Okay.